All right, what's up, everybody? It's your favorite dynamic duo here. My name is Leroy Horton, and this is,
Dr.
uh,
Walter Aka.
yes, sir. And let me tell you, okay, so on the evolution diagram of like surgeons of the mouth, right? As periodontists, we're somewhere in the middle, okay? There's the neophytes, the dental students, probably at the beginning. And then at the very end, the most evolved, the most surgically skilled, the most surgically tremendous and stupendous. Who do we have, Walt?
I-
We got the oral. Listen, I know you got your ego wanting to say you up there, but you not, bruh. I see what they
listen,
do.
listen, I'm not gonna lie. This is the first time I've seen Leroy do anything like this. So I'm with you guys right now. I'm really shocked, but he's telling the truth. He's telling the truth. We got two
I,
superstars here right now, man.
and of that cohort, that most evolved of surgeons in the mouth, we have two of the best and brightest. We have Dr. Jason Auerbach and Dr. Akeyla Brown. Welcome to these two amazing doctors that have donated their time to us today. So I feel privileged. I know Walt's privileged here. Let's have both of you just kind of give a brief 30-second intro of who you are, where you at, all the good stuff, and then we'll dive into some of the dialogue here.
Doc, can you go first?
Sure. So my name is Jason Auerbach. Some of you guys know me as Bloody Tooth Guy. That's probably how I'm most known to the dental community at large. I'm originally from New York, NYU Dental School, trained at Kings County Hospital in Brooklyn, and started a practice called Riverside Oral Surgery in 2007, which has grown, thankfully, based on the people that we've brought into the organization over the course of the last 15, 16, 17 years, whatever it is now, to basically a larger platform called Max Surgical Specialty Management, which now has about 5 or 6 brands and close to 30 surgeons. Akeyla Brown being one of the superstars, as I talk about. She's exceptional in every way, and I'm going to yield to her at this moment. So, Dr. Akeyla Brown, please go.
Hi, everyone. I'm Dr. Akeyla Brown. I'm also originally from New York as well, but I did all of my training in DC at Howard. So I've been there since undergrad until residency. I joined the practice, I think, in 2020. And yeah, I've been there ever since. So in August, I think it'll be year 4 for me, I want to say. I think so. So it's been a really awesome experience. It's growing. I think when I joined, I mean, it wasn't at the beginning of the practice, but I think there were only 3 locations when I got there, and then just exploded. So it's such a beautiful thing to watch, and the team keeps growing, and the practitioners keep getting more and more amazing. And it's such a wonderful group to be a part of, where I get to learn so much. And as the practice has grown, it's also incorporated some different wonderful things at the executive level. And I was recently given the position in diversity, equity, inclusion, and community engagement. So it's just a beautiful thing that's happening. I think it's just a beautiful thing that's happening in all of oral surgery. And that's who I am, and that's where I am.
All right, now, Walt, we got two true New Yorkers here, right? And in true New York fashion, we were talking before we started recording, and Jason mentioned that being from New York, he believes they got the best restaurants. Now, I don't know what it is about New Yorkers. Every New Yorker, oh, the pizza in New York's the real pizza, the best pizza, the steak in New York.
Right.
Are the restaurants in New York the best in the world, or is that just your New York pride showing through and through?
I mean, I think they are. I really do. I mean, I think that whatever is done elsewhere, for the most part, is done better in New York. It's just my feeling.
Okay.
I will say I yield to certain things, and as I was telling you guys earlier, the steak that I had in Houston killed it, and frankly, the sushi in Washington is off the charts. So I'm assuming there are great things all over the world. But I am New
Maybe.
York focused, and despite living in New Jersey, proud to say I'm a New Yorker through and through.
I will say that there is something in the waters when it comes to New York, because my wife hasn't lived in New York for like 20 some years, but still claims New York. It's the weirdest thing. Like
Right.
she spent more time in Houston, but somehow still claims New York. It's a weird. I'm like, you grew you were like 8 when you came to Houston. You know what I mean? Like, it's been 30 years and you're still saying, oh, well, I'm still from New York. And then she swears that, oh, well, Brooklyn and I'm just like, stop. After a while, just stop, So there is something about that New York loyalty. I don't know what it is, man.
All right, but let's talk a little bit of dentistry. And we've prepared some hard-hitting questions that will speckle in, but we really want to hear, we talked about the difference between, or I joked about the difference between, a general dentist, periodontist, oral surgeon. What makes an oral surgeon so unique? Is it the temperament? Is it the drive? Because the amount of schooling that it takes, the amount of authority that you have to have in the surgical field, whether it's private practice or hospital setting, and the sheer amount of responsibility with the procedures that you're doing. What makes an oral surgeon so special that they can handle that?
So I mean, I can answer that. I mean,
Yeah.
I'm sure we both have similar and if maybe different perspectives on it. But so my feeling is, I think what separates oral max. First of all, let me just say this, and I don't want to kind of challenge anything that you're saying, but I don't think that oral maxillofacial surgeons are more special than anything and than any other specialty. I think that our skill set is different and expanded relative to most other dental professionals. I do think oral maxillofacial surgery is the best healthcare specialty, period. That's how I really feel. But I think it's all about the actual practitioner. This is not BS. This is what I really think. I think there are that skills that periodontists have, or that certain surgically minded general dentists have, that are unique and special and great in their own right. So I don't think that oral surgery is better. I do think that our training is significantly, I don't want to say more intense, but it exposes us to things that other dental professionals are not exposed to. And I think that's really where the difference is, that part of our training is not so much that we're doing the things that we were trained to do every day. Most of us are doing, exodontia, dental alveolar surgery, implants, bone grafting, minor pathology, things like that. But the scope of our training prepares us to see things and handle things, and teaches us to make decisions that allow us to realize that maybe some of the things that we're seeing in private practice are not so challenging or not such a big deal to us emotionally or mentally. And so because of that, we're able to handle things. And I don't want to say a different way, but I think that's really what separates us, is that our training is so broad and so intense that our day-to-day becomes more easily handled. I don't know if you hear what I'm saying. I mean, Akeyla, what do you think about that?
I totally agree. I also agree that I think we're all really special. I think that I love to be guided by a prosthodontist. I love to share moments with a periodontist and see how they would handle a case differently than I would. I think we're all really, really dynamic, and I don't think that any of us are. I don't think there's really a hierarchy at all. I think it's a really good team, especially like if we work together well. But I do think that there's a great commitment that we make during that time, and there is a lot of sacrifice. And I do think that there's a lot of pressure that forces us to, I guess, be more relaxed during certain situations that may seem unique to others, but like Dr. Auerbach said, are more day to day and banal. But I think we all have our moments where we're challenged as well, and humbled, even with our great training.
Well, you guys knocked that one out the park. I was trying to set you up for exactly that, to have a moment of humility, right? I was trying to build you up and self-deprecate, and both of you masterfully handled that question. So
well, Leroy, hold on. Let's put it all in perspective, right? What they're talking about is they have to, some programs, most programs, you have to go through med school, right? And so when they're talking about being able to handle certain things that, maybe like a general dentist or a periodontist could not or isn't trained to handle, that's what they really mean. They have that extra training of going through med school. So not only are they doing, and please, Jason, if you don't mind, you want to talk about something like that, just for the normal person that's listening to kind of be able to differentiate how you guys stand out a little more. And I mean, again, you're humble, but we got to talk about that.
I appreciate that. I mean, so about 50% of the programs are what are considered dual degree, 6-year programs where you do med school as well as residency. But I think really the bigger differentiator is the residency based training more than the actual med school. Because when the med school, like, a lot of that, and so just to understand, I finished training in 2003. I did not go to med school. I'm a 4-year trained oral maxillofacial surgeon, full scope. That, again, I trained at Kings County Hospital. We were dealing with some pretty intense stuff day to day. As part of it was a SUNY downstate in Brooklyn. And so I think really where we make our bones, if you will, is in the hospital training program, where we are alongside medical residents in many cases, where we train fully in anesthesia, general surgery. I mean, I covered plastic surgery and ENT. And
Trauma.
and yeah, all that stuff that we see, gunshot wounds, interpersonal violence, motor vehicle accidents, things like that. Are things that I think kind of change the way you see things and enable you to treat things, looking at them from a different perspective, more than the med school. And I guess if you had someone here who went to med school, they would tell you maybe the same, maybe different. But I think for me, what really separated me, I mean, when I went to oral surgery residency training program, I thought oral surgery was exodontia. I mean, or really, before I went into oral surgery, I had no clue how broad our scope of practice was. In our practice that we currently, both Dr. Brown and I are in, we have 4 fellowship trained surgeons, one who's trained in cleft and craniofacial, one who's trained in head and neck cancer, microvascular surgery, one who's trained in cosmetics, like full facial cosmetics, and one who's trained in temporomandibular joint surgery. So we have these surgeons who are trained above and beyond OMFS residency, and it's just, I think that is really what, to get at what really differentiates us is really that hardcore hospital training.
So with that being said, why do you think everybody knows you guys as the people to go to when it comes to third molar? With all that training, right? We've almost eliminated you guys, or just kind of narrowed you guys down to, oh, that's where you go get your wisdom teeth taken out.
Right.
What happened? What how do we do wrong in dentistry where we basically narrowed it down to that aspect with all the training?
That's not really wrong, is it? I mean, that is something that we do. And
I'm not saying that.
Which I'm really proud that I do. And I would love for someone to come to my office and get their third molars taken out. I think that's a beautiful thing. And I love doing it every day. But then, some days we have to do a little bit more. And it's zebras and horses, right? There's more wisdom teeth than there are car accidents, thank God. And there's more wisdom teeth than there is cancer, thank God. So it's not like every day you're going to see amelioblastoma, but every day you are going to see wisdom teeth. That's just kind of how the cookie crumbles. So I don't think it's a lost art. I still go to the OR and I still see some trauma cases and I still do some pathology cases. But then on my day-to-day, thankfully, my patients are coming in to see me, and most of the time they don't have to deal with those issues. And most of the time it is just simple extractions of wisdom teeth. I think that's kind of primarily why. What do you think?
I mean, are you asking me?
Yeah.
Yeah. So, I mean, I think it's a combination of things. I think generationally, if you look at what's gone on in oral surgery, and perio, and with the implant world, and pros doing surgery and all of this, and more surgically minded younger dentists coming out now, there's been kind of an evolution. There was a time where like old school oral maxillofacial surgeons, they kind of felt that they wanted to do more trauma and more orthognathics or TMJ surgery. And if you look at the history of our profession, there were periods of time that certain things were more in vogue than other things. And then I think what ended up happening and this is going to come out maybe a slightly negative slant, but I hope it doesn't, because it's not intended to be. Over time, I think the periodontists were smarter as far as marketing themselves, saying the concept of like, we pay attention to soft tissue, whereas oral surgeons just jam the implant in or whatever it is. And given the fact that periodontists were in the dental schools and periodontists were more closely working, let's say, with the patient population that required dental implants at the time, they were smart, and they got the reputation to understand dentistry and understand soft tissue and speak the same language, and therefore they were doing more implants. I think when I came out, that shifted to some degree, though I think it's still tried and true that periodontists have a reputation of understanding the aesthetic zone better and blah, 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 and all this stuff. And again, I'm not disagreeing. I think everything is an individual practitioner. I think I pay very, very close attention to soft tissue, and I think that there are periodontists who probably don't, and many who do, and many oral surgeons who don't. And I know I'm kind of tangential here in my answer, but the point of the matter is oral surgeons do a lot of wisdom teeth to a great degree because of what Dr. Brown is saying, also because of the anesthesia piece, right? So that's a major separator for oral maxillofacial surgeons, that we do our own anesthesia at a very high level. We're very trained to do anesthesia. And because we do, those adolescent kids who are coming in with trepidation and fear and anxiety are easily handled or not always easily, but are handled by us in a fairly consistent, predictable way. Plus, we take out wisdom teeth pretty quickly, and we're pretty adept at that. Tooth extraction for us is just it's just a very natural thing. So I think that all of that plays into it.
Right. Well, let me ask you a philosophical question. I'm going to build this question, so bear with me for about 30 seconds here. So there's a lot of studies that have shown that level of training can kind of predict postoperative complications, right? There's an old Handelman study looking at OS residents versus GP residents, and then another study that looked at OS residents versus out practicing oral surgeons, right? And so we see that the more trained you are, the less complications you have, the less blood that's spilled during surgery, the less time, and so forth. Given that, I was at the ICOI recently and talked to a number of people, and I see this trend of a lot of general dentists, a lot of them new grads, coming out being recruited by these DSOs, both large ones and small ones, for these all-on-4 clinics. All they do is exodontia implants. And at first, they started talking about how many cases they have under their, they've been doing, how long they've been doing it, and so forth. But then, when you have a conversation and you start noticing from what they're saying or what they're asking, you're kind of figuring out how much they don't know. And you're like, wow, you're doing all-on-4 cases and you asked that question? What are you seeing in the world now, as you said, surgically minded young dentists? Because it's the cool, it's the sexy stuff, right? It's the surgery. Do you see it going in a positive way, or are you worried at all by the trends of, the labs dictating surgery and getting these young docs with minimal experience and throwing them into all-on-X cases?
So, I mean, my response to that is basically twofold. I think it's a good thing that people are exposed to surgery and do surgery. But I will tell you, if you've ever heard anything I've always said, I think you cannot do anything unless you can handle, or you should not be doing anything unless you can handle any potential complication that comes your way. And so as an example, again, I'm fully trained, full oral maxillofacial surgery trained. I did a ton of orthognathics back in my day. I am not the right person to do your orthognathic surgery because of the fact that, not that I can't handle the complication if God forbid there's a complication, but there are people out there who are doing it on a regular basis, who do a ton of cases, and they can handle, it's a quicker case, the fewer complications, and much more predictable results. And so I do think that there is a little bit of an issue that's going to come down the pipe. I mean, I've been in the game for a long time. I see things that happen many years down the road. I am concerned about, forget general dentists, anyone who's not well trained doing full arch doing zygomas, doing pterygoids, doing these things that again seem sexy and seem great, as to use your words, and I totally support them. Like, you know, you got a guy who doesn't really even understand the blood supply to the bone that they're drilling in, talking about and doing a ton of implants that way. You know, I don't think that that's necessarily what's best for the patient, nor do I think it's good for the profession long term. I'm concerned about what's going to happen with and again, I believe in the technology, but I think as part of your armamentarium, and I know I believe Dr. Brown feels the same way, that, you know, zygomas and teres are things that should be in your like toolkit, but they shouldn't be the only way you treat patients. Just like full arch shouldn't be the only way you treat an edentulous or partially edentulous arch. You know, I went and I learned from Paulo Malo in Lisbon, I don't know, 15 years ago, whatever it was. And I understand the evolution of the all-on-4 to the all-on-X and all of that. And I think that I know that there is a very good place for full arch cases and many people to do them, but I don't think necessarily it's always the answer. And then I'll end with this, and I'd love to hear Dr. Brown's perspective on it. I mean, realistically speaking, I think a good deal of the art of surgery has been um, removed from the need for the practitioner, right? So the guided surgery and all of that has really removed the need to really use your judgment in many cases when the guide is working properly. I think what ends up happening, though, and we've all seen it, anyone who's been doing it long enough, guides break or they don't fit properly or they're not exactly right on. You got to be able to think on your feet and to be able to switch. And I think part of, again, I'm not talking about me. I happen to use me as an example. I'm not talking about me. When I started placing implants, I was placing tissue level Straumann implants. Those tissue level Straumann implants had a table on them and you had to use a solid abutment, which means if I didn't put the implant the way it needed to be placed so that a solid abutment could hold a crown or two crowns and therefore have a line of a draw, like, that was a failed case. So now you have an angled screw channel and these multi-unit abutments and all of these kinds of things that can correct for less than optimal surgery. So I think we're seeing it's better, I guess, in that way, but it's also worse because I just wonder what's going to happen to the quality of surgery when all things don't go as planned. So that's kind of how I see.
Okay. All right, Akeyla, what do you think?
Yeah, I totally agree. It can be dangerous, right? If things are in the wrong hands, like great materials and great instruments are in the wrong hands and these new advances are in the wrong hands. But there's also something to be said about getting out there and practicing, right? Like if you do however many all on X cases, after a while, you do kind of know what you're talking about. You do know what you're doing. It's really exciting to see people entering into the surgical field from different avenues. But yes, I mean, you should, for the patient's safety, you should be well versed in in the information. And it is kind of scary to hear someone not like that experience that you had, where you know that these people are placing these implants or doing these large cases, and they have these strange questions or lack of knowledge. So that is concerning. But I don't know what you do about that. How do you circumvent that? How do you fix that?
So here's a question for you guys. Is it the amount of procedures that you do? Because you mentioned if you do more, then you'll feel more comfortable. But to me, I feel like the way you differentiate is also kind of the knowledge that comes with it. Like, Doc was saying, you have to understand the blood supply, low anesthesia. So you have to understand anatomy. You have to understand so many different things. It's not just, let me just do a lot, right? Because if you do a lot and then like something happens where you have a complication and you're like, well, where's this blood supply going? Or where's the bleeding? Where's the bleeding coming from? Right. To me, that's kind of like where we have to differentiate, because you'll have, you'll go online, for example, and Leroy and we talked about this a lot, where you'll see a general dentist who teaches other general dentists how to do thirds and how to do implants. And they're like, well, you can be as good as an oral surgeon, as a periodontist. And I always sit there and go, yes, if you do enough, I guess you can become very good. But without the knowledge, to get yourself out of trouble. I feel like that doesn't make any sense. So I want you guys to kind of speak to all these courses that people are selling online, where, you know, you got a general dentist basically saying, I can teach you how to do as good of a surgery as an oral surgeon or as a periodontist or somebody who does, or even a general dentist who has taken all those courses in those time.
If they're
Go ahead. No, please.
If they're taking the courses and also reading the text, then they're doing the right thing, right? If they really are taking the time to do that, because the information is there. If they're not doing it, of course it's wrong and it's dangerous. But it is I do think there is a combination between doing a lot of surgery and learning how to do it quickly, because that also determines how successful your case is. Surgical time can lead to many complications the longer the cases are, right? So practice and efficiency is extremely important. I don't want to poo-poo anyone learning how to do something and being good at it. And it doesn't, I don't think, take away from the patient pool for us and our ability to still provide a wonderful service. Because sometimes I'll take a course and listen to a general dentist perspective on how they want an implant placed. You know, if I'm doing a case, sometimes I need a prosthodontist there to tell me where exactly they want the implant and how they want it done. I think we can all learn something from one another. And I think the more of us that are doing these cases and the more of us that are becoming well-versed, the more people and the greater resources we have and the ability to learn from one another. But there is that concern that there are people out there who are just, like you said, doing something because it's sexy and it's cool, and they're not taking the time to really learn the information. But we all went to residency and we all practice with some people that do have a degree, have passed boards, and you're like, wow, like you know, so they've read the book, their text strong, they could probably during rounds run circles around you, but I would be scared to see a blade in their hand, right? So like we could tell the story in so many different ways, you know.
So
let
me do a quick follow-up with that. Do you think that because more people are doing implants and a lot more implants are being done, we have an increase in implant failure? Or do you think it's just the lack of training? Like, what do you think is causing more? Because I'll speak for myself. I'm seeing a lot more implant failures. Is it because more people are doing it, or is it because less skilled people are doing it?
Yeah.
I think people are taking liberties that they necessarily wouldn't have taken, you know, when implants were starting to be placed. You know, we waited longer. We waited longer for the graft. We did fewer immediate implants. When I started placing implants, we were very conservative in our thinking. And again, we're talking 20 years ago, and that was already 20 years after the kind of the way it started. But the fact is that I think the more aggressive we become, the more failures you're going to see. And I don't think everyone takes everything into account. Like, for instance, if there's a small periapical pathology on an adjacent root canal tooth, that will affect, small PAP can affect the success of the implant more than most people give that credit for. And just kind of like looking big picture and understanding the comprehensive treatment of a case, the occlusion and adjacent teeth, angulation, just things that you need to think about that when you do more, you think more about. I think just to kind of like answer that first question, or at least my perspective on it, is so much of success comes with understanding, you know, case selection, not just the patient selection, like the actual case of what needs to be done, but the actual patient, and then also your skill set. You have to be totally at one with and aware of like what you can do and what you can do well. And I will actually just kind of echo what Dr. Brown said. There's a guy here who does full arch cases, a general dentist, and he does a ton of them, and he does them extremely well, and he's brilliant. And again, he's a general dentist. And I routinely will call him and ask him questions on cases. And despite the fact that I've done, you know, I mean, I don't even know how many implants over the course of my career, but I don't think that it's necessarily a negative thing to be a general dentist imparting his or her knowledge to anyone else. I think it is. I think, let's be real, an oral maxillofacial surgeon who is good, who is a good instructor, teacher, understands, is probably better, more appropriate to teach that. And I do think what we forget is we talk about like do a lot of cases. The beauty of residency not only is just being exposed to things, as I said earlier, is you do a lot of cases. You get to you learn. You learn in that setting where things are challenging. You're working with, let's say, lesser instruments, and you're working with maybe not an assistant, or so you're working and you're doing a lot of cases in compromised situations, so that when you get to a world where maybe you have access to better instrumentation and better help and all of that, you actually, things are much easier for you. So there's a lot of that too. Talk about like, however many 10,000 hours and you become an expert at something or whatever. So if you get like 8,000 of those hours before you finish residency, you got a little bit of a head start.
Absolutely. And to add to that, I think residency also adds the accountability. And I don't know how OS was, but in perio, you're always having to present your cases. You're doing a ton of photography, intraoperative. You get grilled, right?
Yeah.
And so it puts a spotlight on you. So knowing that someone's going to be looking at this, you end up always doing a better job, right? And that's what I tell a lot of general dentists: hey, take a good photography course. Because if you take a 1 week course or weekend course, then you go back, you're doing your own thing. No one's watching you, no one's critiquing you necessarily. But if you get a good mentor, and like I said, I shadowed, and sorry for my formality calling everybody by their first names, but we were all talking before, and I told Jason that a mutual acquaintance of ours, I used to shadow his dad all the time. Periodontist Tom Sweeney out here in Seattle, shadowed him all the time. My buddy Richard Ansong, a high-profile prosthodontist. And so I would always show them, my cases, and held myself accountable as a GP. And then I saw that same exact thing in residency. And so, I mean, I think that is, obviously the reps, the hours, but also that accountability it's important. But I do want to segue, because we've talked about clinicals, and some of the greater, industry philosophies. But I know Akeyla here has a very special position within the network. That when I watched your video, I jotted down some questions, because I think it's great to see this particular position in a non-institution setting. You see these in big corporate organizations or dental schools, but having someone being in charge and being accountable for diversity and inclusion in a private setting, albeit your network is quite large. What does it look like to be in that position, and what needs were you specifically brought in for to address in a private sector world?
It's not like we have a lot of chasms in our office or in our network that needed to be addressed. It's a group of really great people, and that's probably why it was so easy to create such a position. However, I think it was like, an avenue to present a different perspective and make sure that we were meeting all the diverse needs of our staff and of our growing practitioners, and hopefully that group of practitioners would become more diverse, and that all of those voices would be included. I think that was primarily the idea. And then also, as our patients change, the more offices we acquire, the larger we grow, the more diverse our patient population is going to become. And I think, considering those kinds of things and being cognizant of those changes, I think that was why the position was created.
Okay. So what are some projects that you're working on, or some initiatives that you've thought of and are starting to put to action?
So some initiatives that we're actually working on are translation services, or something that we're trying to incorporate. And I think by doing something like that, more private institutions will incorporate translation services to be more inclusive to different patient populations.
So the
Other thing,
5-year-old daughter that speaks English isn't good enough
no,
for
that's
those?
not, no, that's not okay. That's not okay. Granted, it's good practice for this 5-year-old daughter, but no, we should definitely be providing something more, our ASL patient population. So things like that. Those are some initiatives. Also, more community service based initiatives. Dr. Auerbach's really good about reaching out to different populations, different communities, veterans, doing mission trips, things of that nature. So those are things that we're working on.
Okay.
Dr. Auerbach, let me
Okay.
ask you a question real quick. And this is actually, you just led me into this. I saw that you had done a mission trip to the Bahamas, I want to say, right?
Yes.
With somebody who is as busy as you are, somebody who has multiple offices, kind of running a management company, multiple offices, multiple doctors, why do you have, or how do you have time to go to a mission trip? Because I'm very big on people needing to do a mission trip, giving back, right? We
Yeah.
take a lot as dentists. We need to give back,
Yeah.
right? So what made you want to do that? Why did you do that? Why do you think it's important to do that? The mission trip.
Well, I mean, it's as simple as I'm a very fortunate human being, and I'm fortunate in a myriad ways. But I think the fact that I have, I don't want to say a gift, but I've been blessed with the ability to help people, and I've earned a very good life by doing that. To be able to give back to people who have need, like I just, to me, it's really what we all should do. Fortunately, I've entered a period of my life where, so I practice. I mean, for a little background, I practice about 3.5 days a week: Tuesday, Wednesday, Thursday, half day Fridays. I do business every single night. Um, People talk about work-life balance. I don't really have one, to the detriment, unfortunately, of my children, my two daughters, who are everything to me, and my wife. But the fact of the matter is that I am in love with what I do. I am passionate about what I do. As I've said, I believe what I do is the best thing that one can do in healthcare. And so I was offered this opportunity to go on this trip to Eleuthera. For perspective, it was started by a guy named Jonathan Levine. He is a dentist in Manhattan. His patient is Lenny Kravitz. Lenny Kravitz's mother, Roxy Roker, was from this island originally, and that is kind of how we ended up on the island. And so they've been doing it for a number of years. I think they took 1 or 2 years off in the middle of the pandemic, but it really changed the way I see things. I mean, I was already inclined to give and to help, but just nowadays, and to see that how much these people appreciate it and frankly needed the care. So it's not as simple as go and take out teeth, right? I mean, it's good that we can do that and we can help people get out of pain and stuff like that. But this specific mission trip incorporates digital dentistry. There were three 3D printers there. Sprint Ray donated. There were prosthodontists, endodontists, dental hygienists, general dentists, tons of students from all different dental schools. And so if I was edentulating a maxilla, they'd come and do a 3D, an intraoral scan and 3D printed denture, so that the next day patients had dentures. Whereas, a lot of times you just go, you take out the bad stuff, and you leave these patients dentally disadvantaged significantly. But there's also an educational component. They're going to the schools on the island and in the surrounding islands. And this specific, it's called Glow Good Foundation. This specific foundation is really aiming at, hopefully, big picture, changing the way that so right now we do a lot of exodontia, as I said. 20 years from now, when these 5-year-olds who have been educated about dental health are now the adult population, hopefully we don't need to do all that exodontia. Hopefully it's more, maintenance and other types of restorative dentistry. So that's what drew me to this specific organization. But I've always been all about kind of doing as much as I can for other people.
So I'll switch back to the formal now because I think this question deserves this more than any question here. So Dr. Brown, you teach part-time, the GPR AGD residence, correct? Okay. So I was in a course once and I noticed that when Dr. Ken Reed and Stanley Malamed, when they were talking, no one questioned anything, right? And we had this extremely bright, extremely talented Dr. Amanda Okende, who's a Black female dental anesthesiologist. She's talking. And one of the audience members, I guess, disagreed or thought he disagreed with something. So he asked the question of, you know, I think it was, quote, would anybody with authority say something different? And the whole room kind of got quiet. And she looked at him.
Look at that look. Look at that look.
Yeah, she was like, well, I'm an authority.
Right.
She was like, in fact, I'm the authority,
right.
And I'm telling you it's this. And I've seen many instances of that, right? So my question to you is, as a female of color that happens to be, obviously a tremendously educated and skilled provider and instructor, do you face any challenges, whether it's just by men or by virtue of being, someone that's melanated? What's your experience has been like in that arena for you?
It sounds like you got to get some popcorn.
I'm gonna keep it real. I might keep it like way too real. So
no,
like
please
no
do.
one will ever want to hear me talk again. But like
no, we'll bring you back if you do.
I'm a Black woman. I'm not, I mean, my parents, my mother's like part Caucasian and my father's Jamaican, but I'm born and raised Black woman. My grandmother was from Kansas. Like, I have that in me. I'm an African American woman, and there's nothing lower on the totem pole when it comes to respect than a Black woman. Okay. So, and every day from birth until now, I've had to face challenges, and I've had to see my mother face challenges. And yes, it is jarring sometimes when you work so hard. That's really the hard part, is like you work so hard and you finally come up and you get the same credentials as your colleagues. And you're questioned by everyone. You're questioned by your patients. They use this euphemism like you look so young, but that's not really what you mean. You don't mean that. And how do you address that? How do you say, it's not that I look young, it's that I look Black and I look like a female, and you don't know if I'm prepared to do this because I'm Black and a female. So and it does become, how do I address that? And now I've come to terms with it. I'm comfortable with it. I'm comfortable with myself, and I believe in myself. I think that's another big hurdle, is like, do you listen to this? Do you take that on? Do you question your authority? To have that doctor say that, like, that's a beautiful thing to hear, to trust in yourself, to believe in yourself and say, I am the authority. I know what I'm talking about. No, you're mistaken. And the buck stops here. I haven't had my residents question me or not trust me. I don't know if they go behind my back and then read and see if I was right, but they haven't in my face like disrespected me in that kind of way. But yeah, I've gotten it from my colleagues, I've gotten it from my patients, even in very subtle ways. So to answer your question, yes, I do have to struggle with that. But the more experience I have, the more I trust myself, the more cases I do, the more complications I face and I fix. It helps with that. And I think a big thing, I'm sure you guys all agree, is once you pass your boards, a lot of that goes away as well. You really feel like you belong. What's the parameter now? If I pass my boards, if I'm board certified, no one can say that there's something, my skin color and my sex are not a limitation, and they're not a factor here. I know what I'm doing. And I can manage my cases and take care of my patients. But yes, to answer your question, I've definitely faced obstacles. I've definitely been disrespected. But I do have an internal fortitude that pushes beyond that and silences that noise and allows me to continue to deliver an excellent product to my patients every day.
So
Okay.
let me ask you this. I feel like being able to see somebody do something allows young kids to be able to say, I can do the same. Right.
Mhm.
You see, I'm not gonna get political, but if you see Obama as president, now a bunch of, black kids can say, oh, I can be president too. And they see you as an oral surgeon, where in the past, and I hope you guys would agree, has been very dominated by white males, right? Pretty much
And
males.
still is.
And
Yeah.
still is, right? Exactly.
Mhm.
So you are somebody that they can look at and say, okay, I can do that too. So what are you doing with your position to expand on that and have the community see you and say, yes, this is exactly why you're here, and this is what I'm going to do as a child, right? Like my daughters, I have two little girls,
Mhm.
and they can look at you and say, oh, if she can do it, I can do it too. So what have you been doing to basically push that narrative?
Well, these kinds of platforms have been really excellent. Like having Max promote me and show who I am and advertise me has really, really helped more young people reach out to me on a daily basis. I'm getting DMs. Can I call you? Can I have your cell phone number so that you can walk me through how I do this? And every time the answer is, yeah, sure. Here's my cell phone number. Whatever you need, whatever advice you need, take it. We can sit down. We can chat. We can talk about the application process. We can talk about, residency match. We can go through your list of schools and we can discuss how you want to match these programs to make it easier for you to get into programs. We could talk about your experience graduating from residency and how you're going to pick a position so that you don't have to go through the things that I went through that made it more challenging because of my sex and my race. So I'm constantly making myself accessible. I think being an attending at a residency in New Jersey is definitely a way to, reach out. Also, when we're selecting residents, when we're looking at things, to have a different perspective, to have a woman of color looking at residents, accepting residents, I think that's definitely crucial. So those are ways in which I try and give back and reach out and make sure that there are more people like me entering the field.
Wow.
All the while being talented and being in a team of talented people, right? Because I think I've
Yeah.
seen, obviously, Dr. Auerbach, demonstrating his cases. And I was actually going to ask you later on if we can get you on in the future to do like a short 10-minute case presentation so we can kind of highlight some of your skill sets, but we can talk about that off the air. But I appreciate you even addressing the issue. Sometimes some of these topics, we try to ride the fine line, especially when we're in business, of kind of being apolitical. But it's nice to, have some honesty when it comes to some of these issues that are real issues. And obviously your team trusted you and
Oh
valued,
yeah.
as you said in your video, valued this work and created, helped create that position. So I think that's a big kudos to the entire organization, because I was so interested in it. Because like I said, I've never seen a private network even think about that. So if I could ask you, Dr. Arbash, how did that conversation come up, and what were your thoughts as you started tackling that concept?
I mean, I guess it started when I first met Akeyla. I mean, basically, it was, listen, I happen to be light. I'm a white guy. I'm a Jewish guy, right? I
What?
mean, right?
What?
Let's be real. I'm a 50-year-old white Jewish guy in a world that's a little crazy, right? And the fact of the matter is that I live in New York, right? So in New York, not to say that there's not any concern about racism or whatever, but by and large in New York, people are generally they know people of different cultures and backgrounds and colors and religions and whatever, and everyone is a very, I feel, at least in my experience growing up, has been, everyone's tolerant basically of everyone. Everyone is fine with everybody. That no one, maybe tolerance is a wrong word, but you know what I mean. Everyone is just everyone's good with everybody.
Right.
And so Akeyla and I met. I loved her immediately, and when she came in, she, you know, it was an interesting time because she did join us in 2020. It was, you know, the pandemic, and we were dealing with really kind of like, I thought she'd be perfect for a certain office, and then of course we had to shut down a couple of offices for a period of time, and then she was like unbelievably gracious and willing to kind of like just believe in the fact that like we were going to eventually get it right for her, and it really wasn't right for her at first because we did move her around, and ultimately we found, I think, where she is now is like essentially a perfect place for her. It's her own office and she runs it and she's got a great team and all that. It wasn't that we appointed her this. It wasn't like we like granted her this opportunity. This was fully it was really of her own thinking. She presented this concept. Forgive me if I'm remembering it wrong, Akeyla, but
No, you
and
are.
correct me if I'm remembering it wrong.
Thank you.
But she brought it to me. I didn't hesitate. It was like a totally appropriate thing, I thought, and I thought no one better. Obviously, as free thinking and open-minded as I am, I don't have the perspective, and so because I don't have the perspective, and she does have significant perspective, I thought that would make complete sense. I brought it then to, I don't know if I did, maybe you did, brought it to Susan. So we have a woman who is our chief people officer named Susan Coe. She comes from GW Health. She was their chief people officer. And so kind of, again, this is my memory, it could be wrong, that we put Susan and Akeyla together, and the two of them basically conceived of this dyad, as they call it, basically a clinical director and an administrative director, of this DEI and community outreach, and that was how it was born. We took it to the board. We all agreed that this was totally appropriate, and hence Akeyla Brown, the clinical director of DEI and community outreach for Max Surgical Specialty Management. And listen, I think it's very important to take everybody's perspective into things. And I mean, everybody's perspective. And I think, you know, there's a lot of, you know, kind of, I'll be real, there's a lot of talk like, is DEI a good thing? Is it a bad thing? Is it like, and I mean, everybody has like opinions on it. I think in its purest form, DEI is amazing and should be, and is a big part of what's going to get us really to a good place societally and culturally. I think the only way to actually get to a better place is to have open and honest, free-flowing communication and sharing of ideas. And again, that was why for me it made sense for our organization to have this as a big part of it. And frankly, I mean, we talk about it, we promote it. It's part of what I think differentiates Max. I think it is a draw. I think in that way, maybe it's a little selfish. It's a good thing that we have something like this as a differentiator. It's only part of what differentiates us. But I think Akeyla is the perfect person for it. She's passionate about it. She's got perspective. As I said, she's a superstar in every way. I hope she knows I really feel this way. This is not just words. And so, I mean, I think Akeyla Brown is kind of like, you talk about me as maybe like starting this whole like Instagram dentistry thing. I think Akeyla Brown is going to be like next level, like crazy next level, if that's what she wants.
We're looking forward to that.
Right.
Yeah.
And remember, we had you on our first podcast. So remember us. Just remember us when you blow up. Just remember us. All right. Just give us
We're blowing up together. We're going to the top together.
That's it. We're gonna wrap up here. And I mean, there's so much we could talk about. We could talk about the future of dentistry. We could talk about so many different factors. We'll stop here because I don't think people have enough attention span for like 2 hours.
Yeah.
So hopefully you guys will be able to come back when your schedule does, permits. But Dr. Horton always wants to do this little rapid question stuff. So I'm going to leave it to him to kind of end this.
We all have our quirks. Walt likes to sit there with a pencil to act like he's studious, taking notes.
I do this a lot.
Nothing.
I look good when I do this. Okay. I feel good when I do this.
And I'm a big kind of a nerd when it comes to some things. I used to love that show, Inside Actor Studio. And I don't know if you remember at the end, he used to always ask like these kind of existential questions. And so I want to do it. It's just 5 questions, quick answer, doesn't have to be too in-depth. I'm going to start with Dr. Auerbach because I want Dr. Brown to have the last word as we finish out, but I'll ask the question and each of you can take turns. So here we go. So, are you extraordinary?
I think I am.
Dr. Auerbach, mhm.
Yeah, I think I am.
Yeah, both of you. All right. What is your biggest fear as a surgeon?
Go ahead. My biggest fear, I'm sorry. I'm sorry. My biggest fear as a surgeon probably is some sort of physical ailment that would affect my ability to perform surgery.
I
Dr.
never
Dr.
even
Brown?
thought about that. That's awful. I never even thought about that as a possibility. That's really, really scary.
You just gave her nightmares.
I'm sorry.
She's
That I'll
young.
stop.
Wait until
yeah.
you're 50.
Right,
That I'll
she's young.
stop learning. That's my biggest fear, that I'll stop learning. That I'll close, that I won't be open-minded to learn new techniques and be a better surgeon. I don't want to
Alright.
meet that point.
A good one.
Dr. Auerbach, favorite implant system?
Straumann.
Dr. Brown?
Yeah, I'll say the same thing.
Straumann. Okay. Expensive taste, I see.
Same.
Dr. Auerbach, moments you live for?
One-on-ones with my daughters, live music, and time with friends.
Indeed. Dr. Brown?
Yeah, family time with my mom. Me and my mom are super, super close, so that's a big deal for me. In clinical space, when my patients are happy and like they give me a hug and they really appreciate what I've done, that's magic for me. And then new experiences, traveling, those are things that are great for me also.
All right, and lastly, Dr. Auerbach, 40 years from now, what do you hope to be remembered for?
I hope to be remembered as an amazing father, a good friend, great husband. And from a professional standpoint, I really do hope that I can change the way that large scale healthcare platforms are seen. I think that there's a lot of kind of negativity around this quote unquote bad word of DSO, or, like quote unquote corporate dentistry. But I don't think providing exceptional care and doing it at scale are mutually exclusive concepts. And I really want to change the way that people think about large scale healthcare.
Dr. Brown, last word.
I want to be remembered for being a kind and good person. And I really, really hope that I am not unique anymore and that there are tons of people like me, to the point where my role is just commonplace. That's what I really hope. I hope there's tons more Black girls just like me, crushing it, being oral surgeons, being whatever they want to be, where it's a normal thing. That's what I hope. And I hope I'm a part of that.
Amen to that. Well, Walt, listen, I'm gonna need like another 5-6 hours with this group.
Well, you can't have
They're
that.
two amazing people.
They don't
We
they have
can like
they're-
talk outside of this.
That-
We have each other's contact information. It doesn't have to
Absolutely.
end
No, that's a
here.
given. That's a
Absolutely.
given. But the problem is, when you give him a lot of opportunity and time, he'll take that 5-6 hours, and you need to go enjoy yourself outside of this. So,
But I want to thank you guys so much. I want to thank you, Dr. Auerbach. I want to thank you too so much. So amazing, so incredible. You guys have said so many nice things and made me feel so at home. And I had such a good time. And I've learned so much here. So I just really want to thank you guys for having me so much.
Absolutely.
I'm
Absolutely.
not gonna say anything else. That was it. That was it. You just did it for us. Thank you.
Man.
Thank you guys so much, man.
I'll say thank you too, despite it not being the last word. I just I just want to thank you. I mean, really, this was, and I'm actually taking the last word, which is kind of bad taste. But I will say thank you. I appreciate this opportunity. Akeyla, you know how I feel about you, and you guys are great. And so I hope that you guys continue the conversation. I'm happy to talk about anything at any time. I hope this was a positive experience for you, because it was for me, for sure.
Absolutely. And to all our listeners, we'll put Dr. Auerbach's and Dr. Brown's social media handles, ways to contact them in our show notes. because this is about you. So we want to celebrate you and promote you and the good works and changes that you're making. And also, we want to tell everybody, definitely go back in time and listen to some of our other podcasts. We talk about some similar subjects. We might have some people in common, and then that way, as you might get some of the inside jokes that we make, or you get a good laugh of all the fun poking I do at Walt. But definitely check us out on all podcast platforms, on YouTube. We have amazing guests that make our job very easy and enjoyable. So thank you to the two of you. Flowers to both of you. And we'll say good night to everybody.
All right.
Thank you.
Thank you
Good
so
night.
much.
Thank you for listening to this episode of Truth Be Told. The opinions on this episode are just that, our opinions. Please consult your dental professional before taking any action with your dental health. If you have any questions about anything you heard on this episode, please contact us at Real Dentist with an S. That's REAL Dentist with an S at gmail.com. We would be very happy to return any message that we receive because we love the communication that we have with our listeners.